You'll notice in there, you're taking out the bubble diagrams. We put more of a streamlined approach. Just because there are things listed in your protocol doesn't mean you have to do them, but it's something to consider. They're all tools in your toolbox. So every patient's different, every situation is different. They won't need every medication listed. So use what you think is appropriate for that patient's situation, pathophysiology, and everything. As always, so the other change is suggest things that have suggest beside them. Call me on the med phone before you do them. Should be very advanced things or really freaky, outy things that like need this kind of thing. They're in your toolbox, but I want you to call me and run it by me before you get that stuff. Just because they're higher risk medications. As always, reverse the life threat, slow the illness, make them feel better, and then make them feel like they're respected and getting the care they need. So our definitions haven't changed for pediatrics and adults. One big change is now fire can cancel us on scene. I'm having a meeting in 6 days with them about this. Because if they cancel us and there actually is a patient and there is a problem, that's on them. I need them to be very aware of this. So this should not happen very often. Expired medications are going to just be the way of life for at least the next year and a half. One of our doses of ketamine is out until March of 2019 at this point, the very earliest. So this is going to be one of those ongoing battles. You'll notice we have a lot of medicines listed, like for seizures. There's 3 different benzos for a reason. I don't know what's going to be available every single day. Yes, Versed for some reason is never out of stock. But I would like to get towards more of the Ativan side of things, or even Valium. But I haven't had Valium in my ER for at least 8 months. So, being aware of all the different medicines, the different doses, and the indications for each, and the side effects of each is useful because it gives you a different kind of, the art of medicine comes out rather than just the science. Hey, benzo for your seizure. Like, why am I giving which one? Which one acts faster? Which one lasts longer? Kind of dictates which one you get, which time. Online med control, call me. I've always got this phone, 24/7. I highly encourage, if you miss me once, call me directly again. Because if I'm sleeping and I just got off shift and I'm in a 30-minute dead period, I will wake up to the second ring usually. If you have a question about an EKG and you don't know whether to activate it or not, take a picture, text it to my phone, and then call me. That'll give me time to look at it while you're calling. Other people you can call, the receiving facility should be your second up. Patient's regular physician if they're available. And then if you're doing inter-facility transports, get your written orders, and then the receiving facility from there. Have you ever had a doctor try and take over on the scene? Do they have the card? Do they have like all their, they want to take, like they have to do all of this if they want to take over med command on the scene. So most physicians, which by that I mean MD or DO only, not doctor of naturopathy, not doctor of cathopath, not doctor of acupuncture, MD or DO only. They have to be able to agree to all these responsibilities, and every physician has a little pocket card with their license. If they don't have that with them, which most don't, they can't even start this process. Transports. We didn't change much except for if you were uncomfortable with the transport, call me. I've had 3 or 4 calls already about it. I'll talk you through it. I can even talk to the other doctor on the phone. You know, if there's something that doesn't seem right, if the patient's not stable for transport, regardless if the family wants them transported from facility A to facility B, if they're not stable for transport, they're not stable for transport, no matter how much they want to die en route. So, that's just the sad fact of the case. If you have an equipment with you, like an aortic balloon pump, and you don't know what to do if this thing malfunctions, which is a valid concern, the staff there is not willing to send a staff that knows how to deal with the equipment from A to B with you. We're not going to transport. Too high liability, and it's just not going to happen anymore. We've had discussions with UTMB about this. Because in their protocols it says we will send a nurse, and in our protocols it says we will send a nurse. But every time they're like, we don't have the staff. Well, then you don't get a transport. And it just comes down to it. But first, talk to your soups, and then second, call me if you need me. We've listed out kind of scope of practice, things you can monitor for each level. really big ones are gonna be active ICP monitors and balloon pumps. Especially with balloon pumps, needing like someone to come along with to actually deal with it. All the mechanical things involved. If you go with someone on a transport and they're with you, you work in your scopes. So if they are in charge of that, you're still in charge of the patient. You work together as a team and do the best for the patient in whatever situation arises. Big one, decision-making capacity. So there's a very big difference between competence and decision-making capacity. Competence is a legal definition a judge assigns. You're deemed incompetent by the court. Versus decision-making capacity is something you are judging every day in the field. Yes, they had a beer, but they don't appear intoxicated. They can talk to me, they can tell me the repercussions of what I'm telling them, and they still don't want to go, and you're telling them, hey, this could happen. They know what day it is, where they are, they're alert and oriented, they seem coherent, they can understand the risks and verbalize them back. They seem like they're with it enough. Yes, they had some alcohol, but that doesn't mean they're lack decision-making capacity. Versus the person who's slurring everything, can't even walk, is saying, oh, good. Like, that doesn't count. You've lacked decision-making capacity at that point. Then you transport. But that's a very big distinction. When you're taking away and saying someone lacks decision-making capacity, your documentation should really be a lot. Because that's a high liability situation when they come back and say, no, I was totally with it, I only had one beer. You gotta explain why you thought they lacked decision-making capacity. So that's kind of some of the ways you can kind of put it on there. Implied consent, if you're unconscious, you imply consent by emergency decree. If you're a minor who has a life-threatening illness, like a true life-threatening illness, despite what the family says, if they don't want you to treat the kid, get law enforcement involved and go treat the kid. And the kid's best interest is to not have their life taken. If it's a kid that has a non-life-threatening illness and the parent doesn't want treatment, you can't do anything about it. That's the way it is in Texas. Let's see. Refusals. Let's talk about liability again. So refusals are one of the highest liability deals. Did y'all get that email I sent out about the button battery? Like the kid that swallowed the button batteries ended up getting $450,000 fine? Because the paramedics went out and said, he swallowed a battery, it's all good, no transport. Came back the next day, had esophageal burns where it's stuck in his esophagus, needed 3 major surgeries, and he's gonna have a lifetime of problems from that. The hospital bill ended up being like over $2 million for all the surgeries and everything else. For that one, I think you're okay. Refusals are, by their nature, should be more paperwork than transport. Because you need to cover your ass, you need to cover your agency's ass, you need to show that you tried your best multiple times and multiple routes and multiple people trying to get this person to come. You got your vital signs twice, you've tried everything, so anyone who looks at your chart at the end of the day says, I don't know what else they could have done. Not just patient didn't want to go, I didn't take them, it's all good. You have no coverage when you get called to court on that. So, by its nature, refusal should make you twinge and say, ooh, I don't want that. I would rather have the 100 complaints that we are pushy to go to the hospital, them call and complain to me, than miss one bad case. If that gives you an idea. Questions on that?
What about, excuse me, serial abusers of the system who are lift assist, public assist, but their living conditions aren't that great and they only ever call for something but don't want treatment, transport, evaluation, anything. They just aren't ambulatory in their homes, wherever they call us every night to put them to bed. You know, generally we try to tell them if it's important enough for you to call an ambulance, it's important enough for you to consider going to the hospital and getting checked for whatever is generating these calls. But I'm sure everybody in this room can think of somebody that doesn't meet those criteria.
Yeah.
Where
names.
So, a lift assist is a different beast, and a public assist is a different beast. If they're calling emergency 911, then they never want transport. Like, if you can never get them in the ER for that, That's the best thing, because I've got care managers there who were built to take care of these situations. Their whole job is to keep people from abusing the system and being readmitted and be constantly coming back. And then it's just engaging social resources if we have any to try and deal with the underlying issues. Like, if their house is that bad, they can't get around and they can't care for themselves, then someone has to contact adult protective services at some point, at least get them on the case.
Well,
That's what's gonna fix this in the end. It's not gonna be the paramedics or the medical.
the case I'm thinking of specifically, we've been there with APS and still nothing happens. We've been there with PD, nothing happens.
At the end of the day,
We're not gonna choose not to go.
yeah. At the end of the day, you do your best, and it's frustrating. But at some point, that person will tip over the edge and have like an actual medical condition. And what you don't want to be is jaded enough to say, I've been there 1,000 times, it's the same thing again, and miss that that person had a sudden change in something. And now they actually fell and did break something, or now they actually are really acting weird, and normally they're just cantankerous, but now they're really off. And now they're septic, or they're having a stroke 2 days ago and no one noticed, and that's why they can't get up. That's kind of our job. It's annoying, it's frustrating, but maintaining that empathy and compassion throughout multiple visits to the same problem, and hopefully the system will fix that underlying issue in the end. That's all we can do. Yeah. We've kept the same 3 criteria that you don't have to transport. Treatment of minors. These are the ways you don't have to actually ask the parents for permission to treat. One of the interesting ones is if you live by yourself and pay your own bills, regardless of where that money comes from, you're technically an independent minor, and you don't have to ask the parents for permission. So keep that in mind. And the sequence of from best to least, who can give consent for treatment for the minor. Transporting as people's will. Ideally, we shouldn't do this. Sometimes people lack decision-making capacity and it's in their best interest, so we have to transport them against their will. We have specific protocols for restraint and psychiatric behavioral protocols. We'll get to those in a minute. Use them as needed, engage law enforcement to help for physical restraint, and then give them the medicines to calm down. Hospice patients. Just because a person is on hospice doesn't mean you can't treat their nausea and their pain. You can put an IV in them, give them fluids if they're dehydrated. And if they feel better and don't want transport, that's okay. This is a specific situation because they're on a specific program to ease their end of life at home rather than trying to die in a hospital. So you're there to assist that. You can always call me if they say, it's just not working, the pain's just too much today, and you can give them a little bit of pain medicine, a little bit of nausea medicine, a little bit of fluids, and they feel better and don't want anything. I'm okay with y'all saying, fine, that's good. Contact the hospital. They have a hospice contact. Call them, say, hey, this happened, here's what we did. And if worst case scenario, you can even avoid an admission by doing a direct admit. They won't lose their hospice status. They can be admitted directly to the hospice service to get all their underlying worsening things taken care of. Rather than take them to the ER to treat their pain, they get 1 dose of morphine, they get off their hospice program, they're going to die in the hospital against their will. That kind of stuff. So. Out of hospital DNRs, honor them if they're valid. On the next page, we've got an example one. Has to be signed all those 2 places, all the way down. If someone's missing signatures, if it doesn't look right, if you have a question about it, work them. But if they have a valid DNR right there, honor it. Out of state ones, count 2 if it looks valid. They're pretty close. Also, there's like a little key charm or bracelet they can wear that's like the state of Texas and says DNR on it, that counts too. Yeah, there you go. Everywhere that tab is has to be signed. Termination of CPR. Big changes on this one is, I want a 3-lead and listen to their heart tones. Ideally, you'd print it out. Prove to me they are dead, is what I'm asking you. I mean, I just don't want to ever miss someone who looks dead. You call it the jaw is rigored, but when you put the 3-lead on them, they're still in PEA. I don't ever want that situation. So prove to me they're dead. If you think they look dead, just slap a 3 lead on them, listen to their heart tones, put that strip, upload either print the strip or upload the case file. I'm fine with that. Dead is dead. But sometimes you'll think they're dead, and you put the 3 lead on, and you think, uh-oh, and you start. And that's what I want to see, actually. Rigor mortis is not jaw is locked. Rigor mortis is if I pick you up by the small of your back, your whole body would lift up like a board. What else? So for termination of CPR, I don't think, so for non-traumatic things, 20 minutes of CPR, and you've got an advanced airway, which includes a king if you can't get a tube easily, and you've given your ACLS drugs, and you've treated all reversible causes that make sense, in that case, you can call it. Traumatic is 15 plus advanced airway, plus you've done your underlying reversals, you've done all appropriate treatments you can think of, and if they need a needle thoracostomy, you give them that. I'm okay with that too. Unless these are evident. If they're pregnant, work them, bring them. If they have a lightning injury, like a lightning strike or a high voltage injury, bring them. They can look dead, but they're not dead. If you have an abrupt end-tidal increase, if you have a change from asystole, if you have any neurological request, or if the family wants you to bring them to the hospital, just bring them to the hospital and work them. That's the best way for them to get closure on the case. That's fine. Questions on that? The big ones were the hypothermia and the electrical changes, electrical injury changes. Because you can look dead on those 2 cases and not be dead. You should take them to the medical home within reason and within our system capabilities. Just because they're on the island and they want to go to Tuscaloosa, Alabama, because that's where they're from, it's not going to be honored. Same thing for LBJ. Mainland is reasonable. They get all the care at mainland if our system allows it. Otherwise, you take them to the closest hospital that can deal with their injury or, say, illness. Call your super to try and see what the system status is when they ask to go somewhere near. But if they just had a surgery at Clear Lake, they probably should go back to Clear Lake if we can get them there. Otherwise, try and tell them, hey, we're going to take you to UTMB or mainland. They can transport you from there to Clear Lake once they stabilize you. But ideally, they would go initially to where they just had the surgery or major intervention, or they have all their medical care, because they'll get better care there because they have all the records. Please give as much information to the hospital, pre-hospital as possible, especially on trauma activations. Use a helicopter if you need it. Recognize it's a resource you have. It's a very expensive resource, but if it helps the patient, it's worth it. We are very lucky that we have a giant burn center here, so almost all the burns go to the burns. And that's an amazing resource to have. For now, the strokes are staying at 8 hours from last seen normal. So you got to find out when was the last time you saw them normal. Even with the ones that wake up and they weren't seen until 10 o'clock last night, that's their last normal because they woke up with symptoms. Eventually, this will change. There's major changes down the pipeline to extend this to 24 hours from last seen normal. But it's not there yet. This is the RAT guidelines. We're trying to keep it there. But I anticipate by next year this time, when we do the next revisions, it'll probably be 24 hours. This did not change. Arrows, boxes, follow the flow path. You're also very lucky to have so many trauma centers in this small area. Protocols. All right. Fever protocol. You can now treat fevers instead of saying that sucks you have a fever. So we've given you the ability to give oral medications for the fever. If they're vomiting, you can give them IV Tylenol. If they're not vomiting, it's perfectly reasonable, though, to give them the oral medicines. Of note, kids don't get ibuprofen less than 6 months old. Causes massive gastric hemorrhaging, so don't do that. Anytime you give anything with acetaminophen, ask them how much have you had in the last 24 hours. Because if they're popping Excedrins and Norco, they might have already hit their 3,000 milligrams in a 24-hour period limit. So then you give the ibuprofen. But what you don't want to do is load them with that gram of IV Tylenol because they're vomiting, because they're already in liver failure from their acetaminophen overdose. You'd be like, oops. So, thoughts on that? Saline will also help their fever. They're going to be dehydrated if they have a fever. And it'll lower the core temperature as well. And then the IV Tylenol if they have an indication for it. Don't just give it for funsies. It is more expensive than the actual pill. and you do have a theoretical risk for anaphylaxis from it. So there are risks to any IV medicine you give. So if they can take PO, give them PO. I mean, it's perfectly adequate. Yeah,
Are we going to be getting more accurate thermometers?
yes,
Yes.
Yes. Okay.
but not right ones. Nausea and vomiting. Please treat their nausea and vomiting. The main change on this is, so A, fluids are good for nausea and vomiting. It actually, fluid resuscitation will help your nausea. B, give a dose of Zofran. But if you have to redose the Zofran, I want a 12 lead. I was on the fence about this for a long time, but at the end of the day, if you don't want bad things to happen, a 12 lead is quick, it's painless for them, it's non-invasive, it's cheap, and the day you actually give them one dose of Zofran and then say, I need to pull a 12 lead before I give them the second one because they're still vomiting, and you see their QTC is like 650, you'd be really glad you pulled the EKG before you give the second dose. So, I've had that happen twice. And I don't want you to hurt people. So this is an easy way to avoid harm. Don't split the ODTs in half. I wanted y'all to initially, but the manufactured insert says please do not split these in half. They can't guarantee that the medicine is evenly distributed. So you think you're given 4 milligram, break it in half as 2, but it may be 0.5 in one and 3.5 in the other. You don't know. So we can't break them in half. Questions on that? Pain management. Please treat pain. I don't ever want someone to call in and complain they didn't treat my pain, which is a different complaint than they didn't treat it the way I wanted it treated. So there are many ways you can treat pain. You can splint them. You can give them cryotherapy, put the ice packs on there and help the swelling and the pain. You can try guided imagery and relaxation techniques and try and get their mind off what's happening. You can give them oral Tylenol if they haven't had more than 3 grams of Tylenol a day. These are valid ways to treat pain. But for the person who is sitting there texting on their phone saying my pain's a 10 out of 10 and looking at no distress, I would encourage you to take these routes of pain medications. If they're vomiting and can't tolerate anything oral, IV acetaminophen is another option. If someone looks like they're in pain, you believe they're in pain, and they seem to actually be in distress, please treat them. You can use these as well. You can also give them narcotics. The ketamine is not a first-line drug. It's an adjunct after you've given 2 doses of other medicines. So it's mainly meant for the long transports, or people who are entrapped and need pain management while we're trying to work them out. So that's kind of, I don't want you to say, they got broke bone, ketamine. It should be treat their pain, then if I still have time to transport and they're still in pain, give them the ketamine as an adjunct. It'll make that other opiate pain medicine work better. No fentanyl or ketamine under 2 years old. Always watch out for your acetaminophen dosing totals. And then you can always go lower with pain meds in old people or people who are medically frail. Because you can always get more. It's just very hard to take it back. And it's super awkward when you're trying to suck out the IV line to get that fentanyl back. And they stop breathing. Psychiatric behavioral. We broke it into 3 different parts based on how agitated you are using the RAS score. So, if they're just anxious, like a RAS +1, this is the most effective way to do things. Take them out of their environment, verbally calm them, try and get their mind off what's happening, coach them, see what you can do to actually change the problem. If needed, you can give some Ativan, but ideally you can get most people who are just anxious and anxious people better with verbal calming and removing them from their hectic house and their kids that are making them crazy, anxious, and everything else. Beware of the things that mimic anxiety. This is a short list. We'll get a longer one on the next one. There are a lot of metabolic problems or pathophysiology that will mimic anxiety. So, like I said, 12 lead never hurts. Checking out blood sugar never hurts. Things like this. This one is meant for someone who's aggressive but not intentionally trying to hurt you. It's the psychotic guy who's flailing around, but he's not looking at you trying to come for your throat. So, try the same things. If that doesn't work, you've got medication, you can give. If they have a known psychiatric disease or drunk intoxicated, it's probably better to use Haldol. So, unless, I would like to get an EKG after. I understand beforehand it's not probably possible, but after you sedate them and after they're calmer, get an EKG if you use an antipsychotic is a good idea. There's a longer list of things that can mimic agitation. You can also give Benadryl. So the beauty of Benadryl, it'll stop extrapyramidal symptoms from like the Haldol. It's also a mild sedative. It also mixes in the same exact syringe as the Ativan and the Haldol. They're all compatible. So you can give one shot if you need to. But you're not giving it for a sedative, you're giving it to prevent external symptoms.
Okay.
The violent patient. This is our Galveston norm, or Hitchcock norm. This person is actively trying to hurt you or themselves. This person needs restrained in either an IM dose or an IV dose of some kind of medication. You can still try and talk them down, but at this point, they're coming at you. We're past that. So, this is where ketamine's first up. It will work. You just have to give it a little more time than you're used to. But it won't cause that annoying respiratory depression where you got to intubate someone because you gave them too much Versed. If you can hold them down and put an IV in, this is the preferred route. If it's too dangerous to do that, shoot them with 250 in one thigh, give them a couple minutes, still not working, 250 in the other thigh. This will work. Pediatric, you've got doses here if you need it for the agitated, like that horrible case with like an autistic kid who's just wilding out, breaking everything, then comes at you. This is an option. You could also, instead of ketamine, use Versed by different routes, or Ativan by different routes. This is going to be situation specific as to what you have and what you think is best for the patient. So I'm giving you all that leeway to make that choice in that situation. Questions?
Explain the RAS score.
Oh, will it link to it or no?
Yeah. You have to. Oh.
There we go. So RAS goes from +4 to -4. 0 being a normal person like most of y'all are right now. +4 is the guy trying to kill you. -4 is what you're aiming for when you've got someone on an event. So, ideally, with someone who's anxious, or someone who's agitated, or even someone who's violent, your goal is to get them to a -1. They're drowsy, but they can awake to verbal, and they're not trying to hurt anyone, but they're down enough to where you're not worried about your own safety in the back of the truck for the transport. So your goal is, if they start at a +4, give them the meds and try and aim for -1. But you don't have to keep redosing the same meds. If they get down, now they're only like restless and a little bit agitated, you can go to that protocol and use the lesser meds for that. You don't have to keep hitting them. Well, they're still moving around, some more ketamine. I mean, get them to a -1 is your goal.
Is that something you want to have for documentations, is what they were +4 initially,
Yes.
and then going down to?
+4, and then by the time I got there, they were a 0, and then they're or oops, now they're -4. Had to.
I requested that ESO add that option for you, so they're apparently working on it.
Okay.
But that'd be a good thing. That's a universal way to describe someone's agitation. Like if you come in the ER and say, hey, they're a +4, now they're a -2, I'll be like, oh, okay. That makes sense. It saves a lot of words when you can just use that scale as like a universal thing. It's like using the NIH stroke scale when you talk about strokes. I mean, I can just, if you tell me they're an NIH of 8, I'll be like, okay, I got an idea of what that probably is in my head. Pain, psych, violent. Alright, so ketamine or Versed or lorazepam, depending on the situation. Please don't give all at once. That's where the big bores are. You can do the Ativan and the Haldol if you need to in that point too. And then you can also combine a Benadryl if you need to for that last set. That's the B52 shot that we usually use in the ER. Suspected abuse. If you walk in on, you think it's a kid being abused, or you think it's an adult being abused, it's actually whoever first suspects abuse, they're legally obligated to report it. So it's not, I'll tell the social worker when we get to the hospital, they need to report it. By you being the first person to suspect it, you are obligated to report it. It's an online system. Or you can call the number. But this is like, if there's something serious harm or, like, this will get someone out there now, but there's an online system you can use to do it. If it's like a non-urgent, hey, I think they're just being like neglected kind of deal. And it tells you what you need to know about the person when you call.
Question on that for like management stuff. Do they call us back and because I had to do one yesterday?
Mhm.
Yes,
They'll call you.
Kind of like follow up or
They
just
usually call
ask
you
more?
the same day, if not the very next day.
Okay, so
Yeah.
that's the phone call today.
Does that become the medic with that, or does that involve the agency at this point? I mean,
Whoever saw it has to report it.
okay, so you report it, then you let you guys know, I mean, the agency does get involved, or is it now just you with
No,
the-
it's
just
you
you.
personally.
It is,
So
okay.
you should really, as much as you may not want to, you should probably put your contact information instead of the agency contact information. But remember that it is anonymous as far as nobody else can access that information except for, it's not called CPS or APS. I mean, it'll go to them, but it's the Department of Family, something
Right.
services.
It's a pretty step-by-step thing.
Mhm.
It's like self-explanatory.
All goes
Okay.
into the same thing. But you have
Yeah.
48 hours to report it from the time that you witness or suspect it.
Okay. It's a good idea to put the case number they give you in your narrative of your report as well. That way you can reference it later.
I see nothing.
I've called the people waiting.
All right.
I hear nothing.
Airway stuff.
Sometimes we won't get nursing homes.
Take the airway if you need it. Don't forget they don't. It's kind of what it boils down to. Some people need it. Most people that need intubation have been working to get to that point for days to weeks. The COPD has been off their meds and hasn't been taking anything and are still smoking. They didn't suddenly get short of breath an hour ago or 20 minutes ago and then need intubation when you first get there. This is a slow building process. So by definition, you have time. They may be tripoding and huffing and puffing, but you got at least 90 seconds to plan. And that's the hard part to remember in the heat of the moment. The key to doing all this is having at least 2 and preferably 3 backup plans ready. Taking the 90 seconds to position the patient. The beauty of putting ketamine as our induction agent is, it takes 30 to 60 seconds to work. So that gives you that time while the medicine's working and your partner's bagging them to make sure you got all your stuff, run through your head your backup plans if shit goes downhill, and then make sure the patient is in the proper position to give you first pass success. Because that's really what you want, is first pass success. Easy to make everyone feel better. But you want to plan for that shit show when you open up their mouth that you didn't think was going to be there, and then be happily surprised when it's an easy tube. And that's literally every tube in the ER, that's what I'm doing. I'm planning to see a bleeding variceal pop out and start spurting me in the face when I open up their mouth. But I got suction ready. I got a bougie ready. I've got some kind of LMA or King Airway ready if I need to as a backup. These are the kind of things you think through on every single one. That doesn't mean you need to open the equipment, but you got to have it at hand and have your people around you ready to help you when things go down. So I love this saying, slow is smooth, smooth is fast. If you ever see me intubate in the ER, that's all I'm thinking in my head as a mantra as I'm going in and doing it. It seems like my intubations take forever in the ER. But people say they're relatively quick because I've taken the time to position the patient, got the right meds in, I've double-checked them, double-checked my equipment, and as I go in, it's just muscle memory at that point, finding what you need. Can't see anything, try cardiac pressure. Have someone hold it exactly at that same pressure, and then get your tube. Bougies are an amazing thing. They cost like 30 cents. But like, I considered making it required in the first pass attempts. because they're an amazing adjunct that is cheap and will greatly aid your ability to get first pass success. I highly encourage you to use them at all times. Yeah. Pre-oxygenation, I think we changed on this one. So I want you to slap a nasal cannula on them, crank it up, put a non-rebreather on top of that, crank it up. And a normal, healthy person, they did studies on this, which is a pretty cool study. They did it like we're inducing them for anesthesia and just induced them. And let them sit there to see how long it took them to become hypoxic. It takes 3 to 6 minutes for someone to become hypoxic if you're passively oxygenating them. Now, yeah, their CO2 is going to keep climbing, but that's beyond this point at this time. You know, that's not what you're worried about. It's the hypoxia that'll kill them. So, unfortunately, what we're dealing with when we intubate is you're normally not a normal healthy person. So they're going to tank their reserves quicker. You can help them with this passive oxygenation. So, took out etomidate, sorry, put in ketamine, yay. So, you'll know when it's working because their eyes will start to get nystagmus. It's a great drug for intubation because it's actually going to boost your heart rate and your blood pressure a little bit. So when they're soft on their vitals, the ketamine will help you. So you don't do a clean kill, you know, when they're already hypertensive and you push all your drugs and you go to intubate them, you get that big vagal response and you took away all their adrenergic drive. They dump the pressure and code right when you go in. That's a very clean kill with our laryngoscope. So this will help you avoid that. Ideally, you can push the ketamine, okay, make sure everything's ready, and take a look. Because you probably don't need paralytics. You don't even sometimes need ketamine. Like when you get that GCS3 person, because they have a pontine bleed, you probably can at least try and take a look with no meds. If they don't have a gag, try and look with no meds. Because I mean, if they're already self-paralyzed, why do you need meds to put them down even further if they're already at GCS3? Some people have jaw clenching, some people have gag reflexes, and that's what these meds are meant to take away, to assist you. But if they're down and out, use that to your advantage. You can give sucks if you need to. The doses are there. I like a C-collar on people that intubate, mainly because, not because I'm worried about their C-spine, but mainly because I don't want the tube to come out. We don't have the nice tube tamers that we do in the ER, where it's like a mask that goes around their head and like it will not come out at that point. But I don't want to see when we move them over, the tube gets ripped out. A, it dilates your trachea, which ain't cool, and pops your vocal cords. But B, now we got an emergent ER, an emergent intubation with an edematous bloody airway that we have to go fetch. So anything that will keep that tube from moving. Once you put all that effort and time and risk in to put in, that should be your baby. Protect your baby. If you got time to put a tube down to drain their stomach, I'd much appreciate it. And it'll help you too. Because all that bagging, more than half every squeeze goes into their stomach. Just remember this mantra. Every time in my head, I'm repeating that in my head when I'm intubating. Because I know I've already prepped as much as I can. Ideally, your first pass should be your best pass, which means your most experienced person should take the shot. There are times where it's okay for the less experienced to take a shot. Most of those are going to end up being in like CPR situations, because your focus should not be on airway in CPR. It should be on quality CPR, compressions. If you're worried this is a bad airway, that is not a good one to try and train in. I get that some people need to try though, but if it's, just kind of keep that in mind. There is no harm in dropping a king if you can't get it. People think that's a failure. It's not. The only failure is when now you have to crack the person because you had too much hubris and pride and kept trying, and now they got an anoxic brain injury. And that's on us. If you can't get it, you can't get it. Drop a king. I'll be happy. Yes, when you get to the ER, they might take it out immediately and re-intubate. That's fine. They have way more resources and more people than you do in a controlled environment, relatively, to put that tube in. I got more toys. That's what it's for. But a king airway is not a fail. The failure is when you let them get hypoxic and get a brain injury from that. So beware your pride. I have to keep myself in check all the times. Post-innovation management, the big change here is keep them down. treat their pain. Ketamine's a pain medicine and an anxiety medicine and a amnestic and dissociative. It's an ideal medicine to keep them down after you tube them. You can also give fentanyl if you need to. I want to get away from the paralytics after intubation, the long-term paralytics. Call me if you think you need them, but you better have given something before you call me. That makes sense? It kills my neuro exam for a long time after I'll bring them in, is my main problem. And also, I do worry that sometimes we give the long-term paralytic as a convenience factor rather than actually medical necessity. But if you push ketamine, they will stay down to a RASS -3, -4. They might move around a little bit, but they're not going to be thrashing and bucking and trying to pull their tube out. Failed airway. So, can't oxygenate, can't ventilate. If you're over 12 years old, quick trach. If you're under 12 years old, single needle jet ventilation. We've got spelled out how to do it and pictures on each of those. We didn't used to do single needle. We had nothing actually for kids that had failed airways. The only reason I put it in is because I want you to be able to do something instead of say I'm sorry to the mom or dad. So we'll have to have training on this. We're trying to get pig trachs so we can practice the quick trachs and the single needle jet ventilation stuff. Questions on that? This is something that takes practice. Ideally, we never have to do it. But when you need to do it, you need to know how to do it. This is one of those things you mentally rehearse. So when it hits the fan and you need to do it, you at least have the idea of how to do it in your head. Yeah. This is nice. We're probably going to be able to pull in the vents because we don't have the maintenance contract on them and they're all starting to mess up. So this will be a later thing. But if you want some refresher on what the different terms are and how to use them, the different methods and modes, and then some how do you do the settings. Like if you're on a call and like, hey, we got this person, like is this the right volume? In my head, all I'm doing is calculating your tidal volume. That's why. It's a per kilo basis, just based on their weight. Of note for intubations, you should try your best not to intubate asthma patients. You are getting yourself in more problems than you would ever imagine once they're intubated. Your IDE ratios change, your compliance changes. It's just a horrible mess. That should be the absolute last thing you do. So, all right. Adult shortness of breath, asthma, COPD, wheezing. So we kept the nebs. If you think they look bad, start positive pressure, CPAP, BiPAP early. Run the nebs through it inline. That will help them more than anything in these cases. Unless you think they have a pneumothorax, then don't do that. But you should already dealt with that before because you did an assessment before you started treatment, right? Right. Yeah. All right. So, early steroids are the mainstay for these kind of treatments because it's an inflammatory disease. Inflammation of the bronchi and alveoli, less diffusion, hypoxemia. Take away the inflammation, fixes the disease. If y'all don't give steroids pre-hospital, I'm going to give them as soon as they hit the ER. The sooner y'all give them, the faster they'll get through the ER, and the faster they'll get better. So that's why I'm advocating, if they're bad enough and you think it's an inflammatory disease, please give them the steroids as soon as possible. That's the only thing that's going to fix them. Everything else is temporizing. Fluids, if they need it, they're not fluid overloaded. If they look really bad, set up for the worst case, and then try and treat them as best you can. You can load MAG fast because it's a smooth muscle relaxant, so it's a bronchodilator. You can give epi if you need to. Beware if they actually have like cardiac causes for the shortness of breath, so please check a 12 lead, ideally, before you do that. And then if you're on CPAP, BiPAP, and are anxious and trying to push it away and saying I can't take it, you can load them with low-dose ketamine. That will take the anxiety away, but not sedate them. Let's see what else. If they're pregnant or have myasthenia gravis, don't give MAG. Myasthenia, you'll actually paralyze them and have to intubate them with MAG. If you have to give the steroids IM because you can't get an IV, give them in the leg. There's your stages of failure. Pediatric respiratory distress. So, give them the nebs, position them as comfort, give them oxygen if they need it. You can give oral dexamethasone if they will take oral and you can avoid an IV and it'll just freak them out more and make them in worse respiratory distress. But you've all seen the kid who's like floppy, hard to breathe, and not moving. If you put them with an IV, they don't move. They should totally get an IV and get IV stuff and get, you know, prep for intubation at that point. But if you can give them oral and they can take oral, give them the oral. Or you can give IV, IM, solumedrol. Dexamethasone takes longer to work, but lasts 3 days. Solumedrol works faster, doesn't last as long. So that's why that one's IV, IM versus the dexamethasone's oral. Same thing again, just PD dosing. Croup bronchiolitis when the season comes around again. Suction, because then we got tons of secretion usually. That'll help them out. You can give the oral or IVIM steroids. You can give the nebulized epi. It's 5 milligrams. It's higher than our old dose, but honestly, that's what I'm gonna give them when they get the ER. That will either help them or not help them. Either they'll get worse or they'll get better. It's not gonna tax their heart to nebulize that much. So, if they're rapidly deteriorating, you can give them the IM epi. If you're at that point, you should already be set up for intubation, to see if in case they get worse. Same deal though. Early steroids for any inflammatory disease. That's generally what this is. And that's why the racemic epi works, because it's inflammatory disease and you vasoconstrict and take the edema down in the airway. Heart stuff. Pit crew method. I sent out that video. I think it's what we should do. It makes sense. It's a change. It's annoying, but it'll help the patients. We already have a very good ROS rate. I would like it to be even better. What else do we change here?
If you've got the see-through function, you don't have to do pulse checks. You would do a pulse check only if you see an organized rhythm with an end tidal greater than,
10 more.
I think they put 40, that was the ZOL.
20.
Or 20,
20,
and out rate
yeah.
greater than 40. And then the number 4 there, not intubate.
Oh yeah. For almost all cardiac adult patients that like go down, you have to do CPR, intubation's a second line thing. Number 1 should be good compressions. Do the passive oxygenation. Don't worry about the airway off the bat. Do at least 2 rounds of CPR with a passive oxygenation. If you think it's going to take away from your CPR, just drop a king tube, be done with it. Yes, it's nice to have a definitive airway, but that's not their problem at that point in time. Which is different than pediatric codes, because usually they code because of hypoxia. So do CPR, try and get the airway. Can't get the airway, drop a little king tube, whatever you can do to get them oxygenated. Because that's usually what will reverse their CPR pause. But intubation is sexy and fun. We all love to do it. But at this point, what's going to save them is the compressions, not the airway in an adult. This never changed. Pulses VTAC, you can give them amio. If you continue to have VTAC, you can give Lido as a second one. You can also do double defibrillation if you've already shocked 5 times. Yeah. The idea behind this is usually it's super fat people and the electricity is not enough current to actually hit them. So you put 2 pads on the front, 2 pads on the back, and you synchronize defib at the same time. But it should be for more than 5 shocks. So that's a rare thing to do, but it's another tool in the toolkit because you have to have the supervisor anyway to get the second monitor. I want y'all to work them on the scene because if there's no point in working them and bringing them if their best chance is right there. And if they lose them, then you have PE, or if you have a systole afterwards and there's nothing left after you do your 20 minutes, call it. But if you get ROSC, if they're not, you can give them fluid, give them oxygen if they need oxygen, otherwise don't. You can do an epi drip if they're hypotensive and not responding to fluids. And then we're going to list all the reversible causes just to have them in there. Just because they coded doesn't mean you have to give all of these. It's whatever's reasonable. If it's the Dallas patient who missed 3 sessions, yeah, they probably are hyperkalemic. I should probably treat that. But otherwise, you don't have to push calcium bicarb on everybody. Questions on that? ACS, the only real major change is we're switching to the tablets for the nitro, and then I'm giving you nitro paste. So, nitro paste, slower onset, variable absorption, but it's a good basic, it's the equivalent of doing a drip of nitro. I don't know if you notice it, but like 0.4 of nitro is 400 micrograms. You're doing it every 5 minutes. So what you're basically doing, if you pop them a tab every 5 minutes, is giving them a drip of 80 a minute. So we're basically giving you the equivalent of just constant release on the paste. If you need to remove the paste, they start to drop their pressure, remove the strip, wipe it off, and then wipe it with alcohol. That will deactivate it. Same thing goes anyone else that has any other patches on, like people have fentanyl patches and you need to take them off, wipe it with alcohol or it's still going to absorb and you're still going to have the problem. So alcohol deactivates it. If you have a question about an EKG meeting criteria, call me. Text, take a picture of it, text it to my MD phone, and then call me like 30 seconds later so I have a chance to look at it. There's a lot of mimics in there, but the people who have a good story and their EKG is concerning, I'd rather y'all activate than not activate. Bradycardia. Let's see. What did we change in here? For sedation, for when you're pacing people, pushing ketamine on them. If they're already being paced and they're still hypotensive, you can do an epi-drip. Epi will give you both your blood pressure and your heart rate back. So, something to go in there. Beware of pediatric bradycardia. It's usually hypoxemia. Bagging them actually might bring them back from that.
Your epi-drip's going to be different there than it is in your cardiac arrest, by the way, you guys. Same as how to mix it and titrate it.
Don't pace people if they're hypothermic. That'll come up later. And if you're pacing people, check a femoral pulse, not a carotid pulse. CHF, got the transdermal nitro for you. BiPAP them early if they need it. We still have the IV enalapril for being hypertensive and symptomatic from it. If they look like CHF, fluid overloaded, super hypertensive, it'll help reduce their afterload, which will help their heart work better. You can give them, yeah, otherwise I think the rest of that stay the same. If you think it's CHF, but they also have smoking and they could have COPD, it doesn't hurt to give them nebs. It just probably won't help if it's pure CHF. Not all that wheezes is asthma. Tachyarrhythmias. So this is the confusing part for almost everybody, because when you look at an EKG, you probably don't even notice you're doing it, but what you're really seeing on an EKG is it wide or narrow complex, is it regular or irregular? And then you process that to say, this is a narrow, irregular tachycardia, this is AFib. But in your head, you've already done the first part and you just omit it from thinking about it because you've been trained that way. I've just taken out the fancy names and I kept it, is it wide or narrow, and is it regular or irregular? If it's unstable, it's easy, right? If it's an unstable thing, give it electricity, put it back to stable land. If you've already tried cardioversion, you can give amio afterwards. Stable, narrow, regular complex tachycardia that does not sinus tach. So we're talking about like SVT. Stable, narrow, and regular. You can try the revert maneuver. I think I sent you all the link on that. You have them blow into the syringe, and then right then when they're about to pass out, you put them back and put their legs up real fast. You're basically vageling them by pushing, having them blow into the syringe real hard. And at the last second, when you put them back and put the legs up, you're getting a massive prelude bolus into their heart. And that stretches the atria. It doubles the effectiveness rather than just doing vagal maneuvers. Safe, effective, why not try it? You can give them fluids. Am I actually helping this? You can do adenosine. We changed it to 12 up front. No more 6. Just hit them with 12. 12 and 12. It's going to work or it's not going to work. Why do 6? Dilt, if you need to, be cautious and diltize them in people that have heart failure, like advanced heart failure. because you'll drop their preload and then they'll go hypotensive on you. So just a word of caution. If you think that their SVT is from them being an alcohol withdrawal or just smoking some cushion meth, then treat them with some benzos first. That actually might break them out of it with the fluids. Because they're having too much adrenergic response, take that away with the benzos, and their heart goes back to normal. Or they're in alcohol withdrawal, give them the benzos, heart goes back to normal. So instead of treating the rhythm, treat the underlying problem if there is one there. Stable, narrow, and irregular AFib. So it's the same AFib pathway. You can try some fluids if they look like they need it. It might help, it might not. You can try diltiazem, look at the dosing. I changed it to 0.25 the first time, 0.35 the second time, but there's max doses on there. Almost everyone in Texas is going to meet the max doses. Slow push is the idea on this. If you rapid push it, yes, they will get hypertensive like everything else. It should be slow push. And the same deal. You can get AFib just like you can get SVT from smoking meth or going into alcohol withdrawal. So try that first if you think it's the actual case. The goal of all this is to not try and push. If you're worried the person has or WPW, if you give them diltiazem, they will die. You won't get them back. That's why I've kind of broke all these out like this. So, if you have a stable, wide, complex, regular tachycardia, try amio, and if that doesn't work, and they're decompensating, you can cardiovert them, because they're unstable now. But amio for wide complex is basically how it's going to roll out. That being said, other things can cause it. If they've missed dialysis and they're in stable wide complex tachycardia, probably behoove you to treat their hyperkalemia. And that might fix it. Think of the underlying causes rather than just the rhythm itself. Stable, wide, irregular tachycardia is the dangerous one, because then you worry about, are they actually a WPW patient? And if you give them any of the blocking things, adenosine, diltiazem, it'll actually kill them. So, amio. At the end of the day, if it's a wide complex tachycardia that's stable, just give them amio. That'll be your first line. And then you can do lidocaine as a second line if you need to. Torsades, mag, or electricity, depending on their stability. Allergic reactions. So I'm required by the state now to give you a lecture on allergic reactions because some senator's son or daughter died and EMS didn't recognize anaphylaxis. So this is going to be our protocol and that lecture at the same time. So, if you have a bee sting and the stinger's still on there, scrape it off, don't pull it off. If you squeeze and pull, all you're doing is injecting more venom that they're already allergic to. Not going to help. Put them in a position of comfort. Give them nebs if it'll help them. IM, epi. Early epi is the best thing for true anaphylaxis. So it's not just, I've got an itchy rash. It's my airway is swelling, I'm tripoding, and I'm looking like I'm going to die. Epi is always the answer. If you give, so steroids are the best thing to help this once the epi's in, because this will actually stop the progression of illness and reverse it long term. The anaphylactic range actually works over about 4 days. So that's why when we discharge these people, we give them 5 days of steroids to keep from happening again. The earlier you get this in them, the better. Benadryl, antihistamine. Your problem with allergic reaction is histamine release, so you're countering that. Fluid preload, load them as much as you can with fluids, assuming they're going to become hypotensive on you. If they're bad enough to get IM epi, start an epi drip. This will prevent them from worsening. You have a natural enzyme that eats up epinephrine normally. And the reason we redose after about 5 minutes is it takes about 5 minutes for it to work. And it eats up all your natural epi. You get around that enzyme by giving a constant drip of epinephrine. So they won't rebound and get worse on you again. This is actually per American Heart Association guidelines, the 2017 version. So if they are that severe anaphylaxis, please do this. If it's the mild, moderate, and you're like, oh, they don't look bad at all, You can go, you know, the steroids and the Benadryl and the fluids and everything else and watch them and see how they progress. But when they look like dog shit, please hit them with Epi and give them Epi. Hypoglycemia, I don't think anything really changed in here except for if you have to drill them to give them sugar to get them back alive, they are coming to the hospital. We are not going to take the IO out at home. You literally broke their bone. So please bring them in here so I can chastise them. Questions on that? We do not remove IOs. And we send a link to an insulin chart so you can be like, all right, they take Humalog, it acts in this time, its peak is this time, it peaks at 3 hours and we're 5 hours out, so they're probably past the peak and they're eating, they're drinking, they're probably okay. Versus, I just took Lantus and it lasts 12 hours. You're probably going to have to come to the hospital because you're going to keep dropping your sugars even after I leave. And it's a good way to explain it to the patient so they more information to get them to the hospital. I think on the pain part, management too, there's a little blurb on you can give lidocaine through the IO for the pain. It's a nice thing to do because you did break the bone for them. So the dose is in there. Hyperglycemia is basically dehydration. So that's the dehydration makes a metabolic acidosis, which makes you pee out more glucose, which makes you more dehydrated, makes you more acidotic, and that makes that loop. That's why they're Kussmaul breathing and tachypnic. And that's why they get altered. And that's why they get hypotensive and die, is the metabolic acidosis. Fluids are the mainstay of treatment for this. Wash out the glucose, and that will help their metabolic acidosis and dehydration. So we're giving you pretty liberal amounts of fluids. Be careful in kids. So you can give them the fluids. They need it. Just don't pressure bag it in a kid. Because the problem is if you got such a high level of glucose for a long time and a high level of glucose in your brain, in your serum for a long time, you drop it with the fluids in their serum, all that glucose from their brain attracts the water, and now their brain swells and they get cerebral edema. So, there's a certain rate to drop it. This amount will not drop them unsafely. Just don't pressure bag it in 5 minutes, is all I'm saying. But they need fluids. We're not at the point of giving y'all insulin, so no. And also search for the cause, that'll help out. Did they go out binge drinking or binge eating last night? Do they have underlying sepsis knocking them into DKA? That's usually what's happening. There's something that kicked them into it. Did they miss their meds? Are they out of their meds? There's usually a reason people go into DKA. If you can find it, that's helpful. Environmental stuff. So hyperthermia is what we deal here in Texas all the time. The big distinction is, are you altered or are you not altered? If you're altered, go full bore. If you're not altered, try and do passive stuff. Cold fluids help. Hyperthermia from environmental sources is not a fever. So they're 103 degrees temperature, don't give them Tylenol or ibuprofen. It's not going to work. It's not going to work. What you need is take them out of the environment, cool them down, either passively or actively. Give them Zofran if they're nauseated. If you're actively cooling them with like cold sheets and fanning them and trying to get the evaporation to work and they start shivering but are still altered, you can give them some Ativan for the shivering. That'll help with that. If they're still shivering enough to where they're still raising up their temperature from the shivering and they're still altered, give me a call. I can give you some medicines for that. Opposite side of the spectrum, hypothermia rarely have to deal with. But I trained in Pennsylvania where this was 9 months out of the year. So if they're bad enough and their temperature's under 90 degrees, be careful moving them. Moving someone who's hypothermic can cause a tachyarrhythmia. They're very fragile. So minimize the amount of agitation and movement for the patient. They will be like a sloth. They'll be very slow moving, very slow speaking and obtunded, but still able to talk a little bit. They'll have very diminished vital signs. They'll be hypotensive, they'll be bradycardic, but that doesn't mean you need to pace them because they're bradycardic. Because the problem is the underlying pathophysiology. What they need is warming. That will jack all their metabolism up and get all that back up. So, if you have to cardiovert them if they go into an unstable rhythm. You can give ammo if you need to. call me before you pace these people, because they almost never need pacing. What they need is warming. And the appropriate way to warm them is not by shocking them multiple times. It's not gonna help. Excited delirium, everyone's favorite demon. So, we're gonna give ketamine, is what it boils down to. You could also choose to do the Versed. You could also choose to do Ativan. The main thing that's different than the other one is, if they're being held down, they're already on drugs, or having a psychiatric emergency, they're already by default dehydrated and a metabolic acidosis. Now they're getting held down and straining and releasing all these catecholamines, like epinephrine and norepinephrine endogenously, and they code. Bicarb calcium up front. That's the only chance you got besides CPR to get them back. So you're assuming they've sent themselves into such a bad dehydrated and metabolic acidosis that they're now actually hyperkalemic, and that's what made them code. So that's what we're going to push up on. We're increasing the amount of calcium y'all carry, because almost all my protocols have tons of calcium in them. 3 grams of calcium gluconate is an equal amount of calcium as 1 gram of calcium chloride. So that's why it's 3 grams. I don't think we carry calcium chloride, so that's okay. Hyperkalemia. Hyperkalemia can do anything with the heart. It can make you tachycardic, it can make you bradycardic, it can put you in any rhythm. It can make a white, complex, and nasty looking. If you think they're hyperkalemic, they have a reason to be hyperkalemic, and they're symptomatic. Treat it. This is not for the person who just feels a little short of breath, has a relatively normal EKG for them, and wants transported to the ER. This is for, I have a new tachyarrhythmia that needs to be dealt with. If they have especially a widening QRS, the more EKGs you do, the QRS is widening out, and the patient continues to look worse. This is what this is for. So albuterol is actually the fastest way to get their potassium down. It acts in seconds, but it only lasts seconds. So you can put them on continuous nebs. That'll buy you enough time to get an IV, and then give them the calcium. The calcium stabilizes the cardiac membrane and stops them from coding. Everyone wants that. Bicarb is actually to narrow the QRS, because the sodium works competitively with the potassium, but B, the bicarb part of it will actually, the pH change will dissociate the potassium from the cardiac membrane. Avoid calcium, or be very careful if you think they take digoxin. Call me on that one. That's a gut call. Theoretically, you can poison every membrane in the cell and the heart and make it stop beating completely. And then be careful with bicarb and calcium gluconate, because they can precipitate, so make sure you flush the line good between them. Hypotension. So here's your different kinds of shocks. You should treat the underlying cause of the hypotension. Fluids are a good mainstay. If you think they're cardiac hypotension, though, go light on the fluids and recheck their lungs between each bolus. If you're worried they have an aneurysmal leak from the aortic aneurysm, call me and I can help guide you through it. That's a special beast in itself. If you have an undifferentiated hypotension, and it's not any of these obvious things, give them Levophed as your first drug after you've tried fluid resuscitation. You don't want to start off with Levophed though. You want to try fluids, because if your pipes are all the way dehydrated and empty and you clamp down even further, you'll get your pressure up and you'll feel good about it, and you'll get them in the hospital and your chart looks fine. But in 3 days they'll lose their fingers and toes, because you basically vasoconstricted all their peripheral arteries with no fluid in there to keep them open. So fluid load first. Still going hypotensive despite fluid loading, Norepi.
What is the proper fluid bolus amount for this particular activation?
So up to 30 per kilo if you're not cardiac, and then 500s, or up to 500 on that one. If in the middle of this massive fluid bolus, that's a lot of fluid to give somebody, 30 per kilo, they're still dropping their pressure despite the fluids, I'm okay starting this. Just continue the fluid with it. But you have to at least try the fluids before you jump to the pressors. Overdoses. Oh my God, we expanded the hell out of these. So, opiates. I love giving 0.4 Narcan if they're breathing. Like, you don't want to take someone who's obtunded and out of it and then make them a violent jackass who's vomiting and pooping everywhere in the back of your truck. 0.4 is a good dose to me for that. It's enough to get them breathing and ventilating, which is my goal, not really mental status. Because my goal, like we talked about earlier, is like lightly sedated and wakes up when I talk to them, but goes back down. That's what your goal is with this too. I want them to ventilate. So, yes, I can make them ventilate if I push 2 or 4 Narcan. But you're going to have all kinds of consequences from that. You can always get more, but you can't take it back. That being said, if they're a code and they look like an overdose, give all 4. If you think they look bad and they are stop breathing, give 2. But otherwise, titrate your dose to your effect. And just explain why you did it. I mean, if they have a dystonic reaction, you can get Benadryl. Cholinergic poisonings are rare, but we're in farmland out here. I guarantee you, if you see a true cholinergic poisoning, you should call the hospital way ahead and tell them I got one coming in. Every hospital has a giant vault full of powdered atropine for these exact reasons. You will end up giving grams of atropine. Think about that to these people. Because your goal is to stop the bronchorrhea, and that's what clogs up their lungs and stops their oxygenation. But to do that, I mean, it just takes massive amounts of atropine, more than we have. So A, scene safety and your own safety, because it transfers, and B, atropine early and often. Stimulant intoxication is way more common. Please give them Ativan if we have it. There's your doses. TCA overdoses are a very specific one. If they have a widening QRS, hit them with bicarb. That will fix that. The widening QRS is what makes them code from a TCA overdose. Beta blocker and calcium channel blocker overdoses, I put specific protocols in there. March down this and see if the patient responds. If the patient responds to the calcium, hold. It doesn't mean you have to do everything at once. The reason there's a difference in pressors between the beta blocker and the calcium channel blocker is because in a beta blocker overdose, you're going to be hypotensive and bradycardic. Epi fixes both of those. Calcium channel blocker, you're just hypotensive. I just need the pressure, so I get the norepi. Make sense? Seizures gave you a lot of leeway what to give. Obviously, don't forget the easy stuff. Like EKG and the blood glucose are nice, because it's always poor function to like give seizures Ativan or benzos when it's actually VTAC, and that's why they're flashing around. We had that happen last year in the ER actually. I've given you multiple different ways to treat it. This doesn't mean give all 3 at once. Use what you think, A, what you have, and B, what you think is appropriate for that patient. If they take Ativan at home, give them more Ativan. That makes sense, because it obviously was working for them. Evidence says Ativan is better than any of the other ones, if we can get it. It'll break them faster, and it'll keep them from coming back into a seizure during your transport. But there's all the doses, adult and peds. Sepsis, so these are the SIRS criteria, systemic inflammatory response. If you have 2 of these, plus you suspect an infection, they're septic by definition. So you'll notice only 1 of these I need to draw blood. The other 3 are clinical. If they're hyperventilating, if they're tachycardic over 90, not even 100, and if they're febrile or hypothermic. Hypothermia in sepsis has a higher mortality than being hot in sepsis, because it shows your body shutting down from the infection. So keep that in your differential for people. If so, lots of fluids. And then if they still are hypotensive or getting worse despite the fluids, norepi. What else? I think that's about it for sepsis. We're not at the point of drawing blood cultures and giving antibiotics. Ideally, in the future, I would be at that point. But stroke, do your pre-hospital assessments, get all your history you can, because honestly, most of my history comes from y'all when y'all bring them in. The family either there and distraught and can't tell me anything, or they're useless to begin with, or the patient's by themselves with y'all and the patient can't talk, or is not reliable anyway. So grab all the bottles you can, last known normal, most important. When in doubt, activate. I can always cancel it, but I'd rather catch all strokes than miss some. We generally allow permissive hypertension in strokes because there's no reliable way to tell who's a head bleed and who's an ischemic stroke. That's why you get weighed and you go straight to the CT for that exact reason, is to look for blood. It's not to look for the stroke, it's to look for blood. And as soon as I see blood, then I am aggressively hitting their blood pressure down. But if I see just an ischemic stroke, or I'm worried about an ischemic stroke and there's no blood, the only reason I treat the blood pressure is so I can give the clot busting medicine. But otherwise, I let their blood pressure ride. Because you basically got a pipe with a giant clot in it, and there's very little leaking around it, and that's the only thing that's perfusing down here in the brain. If you drop the blood pressure down here, nothing's getting past the clot, and this is all dead now. So we generally allow really hypertensive states. Syncope, please try and think outside the box on syncopal causes. Is it their heart? Is it their lungs? Is it an infection? Was it a seizure? Was it a tachyarrhythmia? And these are kind of things to kind of go through. Hypoglycemia too. Don't just say, hey, they passed out before, it's all good. Or that, hey, they're orthostatic, that's fine. Like, cast a wide net and then narrow in as you get better. OB stuff, active labor. You should measure the frequency, duration, and interval of the contractions. Assess your vitals, keep them NPO. Early notifications, so I get more notice to get all my resources ready is very important. We look at the perineum, we do a visual inspection, we do not do digital inspections. Don't say I didn't tell you.
Argue.
This is the dividing line.
Nope.
Do you have crowning or do you not? If you have crowning, pull over, deliver the baby. Done. If you don't have crowning, drive faster. Don't delay transport to get an IV, but if you can get one in or out, that'll help. And then if they do deliver, let the baby breastfeed. That'll help stop the postpartum hemorrhage. Don't delay transport to deliver the placenta. It's going to come out in or out anyway, but just note whether it comes out or not. And at that point, you've got 2 patients, so it doubles your workload and also doubles your charts. Precipitous delivery, we got you the way to do it. The normal birth pathway, including like beware of meconium aspiration. So as a baby, you're peeing all the time, you're swallowing your own pee in utero. That's normal. Sorry. But it's not normal for you to take this nasty, thick green stuff and poop it out in utero. And it'll cloud all that fluid in there, and then when you start to gasp, because you're in respiratory, you start to get distressed when you're starting to get born, you try and cry, it goes down into your lungs, and it's like concrete. It's a thick, green, blackish concrete. And it can actually obstruct your airway. So that's what the meconium aspiration protocol provides for. So while delivering a baby is a BLS skill, you should prepare for the worst case scenario. That doesn't mean because they're coming in it should be downgraded to a BLS and have the paramedic drive if you're worried that it could go wrong. And I always anticipate it'll go wrong. It's just how I think. Breech put delivery. The foot comes out first and you're like, oh shit. And then we gotta pull over and get the paramedic in the back. Not cool. Nuchal cords around the neck, what to do. Prolapse cord, what to do. We got links to the different maneuvers to actually try and help shoulder dystocia. And if you can't get it out even then, call me, I can give you a third option, but it's not pretty. Meconium aspiration, like I said, is a very rare thing to actually need to do this. If they're in respiratory distress and starting to go downhill from the actual thick meconium everywhere, that's what this is indicated for. You basically intubate them, try and aspirate. If it's still not doing that, take the tube out, and you'll probably be clogged full of meconium. and replace it and then try and aspirate. But it basically clears all the junk out of the airway. Neonatal resuscitation, once again, one of the things we rarely do, but when you need it, you need to know how to do it. Try and bag them first if they're apneic. That often will stimulate them to breathe. If that doesn't work, start coding them. And then your doses for everything are there. Eclampsia. I gave y'all a super aggressive eclamptic protocol. It is a high mortality rate condition. So pregnant in the last trimester or up to 6 weeks after pregnancy delivery. Of those 6 weeks after, almost all, 90%, are in that first week postpartum. So keep that in mind. But they will look bad. They will look edematous, like 2, 3+ pitting edema in their legs. And they will have had a seizure. And that's what the call is for. But they usually, that first seizure is very brief. 30 seconds, a minute, and it's over. You're like, what happened? The reason we give the MAG is to stop the unrelenting tetany of seizures that happens after that. They go into status, basically, and don't break. So the MAG stops that. That's why we give this aggressive MAG dose. If they have a seizure, treat the seizure with benzos like you normally would. Just make sure you get the MAG in them, because that'll actually stop them from going into that status. Also treat their blood pressure, because what usually kills them, besides the seizures, is the blood pressure jacks so high they pop their blood vessels in the brain and have a hemorrhagic stroke. So we treat their blood pressure pretty aggressively. When you're giving high doses of MAG, watch their respiratory status and watch their deep tendon reflexes. Bangular patella with the stethoscope. When those go and there's no more deep tendon reflexes, the next thing to go is the respiratory drive. So you probably should stop the MAG at that point. That's all I got to say on that. Pain and bleeding in pregnancy. Get as many IVs as you can. You don't know whether this is just normal bleeding or if they have an ectopic and they are about to rupture in their belly, or they have a placenta abruption and they are just going to massively exsanguinate on you. So prepare for the worst, expect the best. Give them fluids. You can give IV Tylenol for pain. Because someone's in pain and pregnant doesn't mean you can't give narcotics. It's just, if you give narcotics and the baby delivers, be prepared for neonatal resuscitation, because it crosses the placenta and will depress the respiratory drive of the baby. But like, if the pregnant lady falls and breaks her femur, you should probably give her some narcotics. Not just here's your Tylenol. Trauma is the last section. Most of the trauma stuff did not change. Treat them right. If they are a multi-system trauma and they look bad, activate them. Your goal for blood pressure and trauma is 90. That being said, when you get to the bay and pull them into wherever ER you go to and the trauma surgeon freaks out because their blood pressure is 90, they're going to start aggressively fluid resuscitating because they're not thinking about it. But what happens is your body is automatically going to start clotting and trying to stop that bleeding, but they got low blood pressure. If you yank them up to 120 over 80, you're going to blow out that clot and they're going to keep bleeding. So we allow permissive hypotension in these cases. MAP of 65, systolic of 90. I'll take either. If you have an open fracture, so I've expanded this to open fractures, not just long bone. If you see bones broke in their body, give them Mancef. We up the dose to 2 grams up front. It's not going to hurt them and it might help them. TXA is the main change in all the trauma protocols. So the criteria are listed here. It's most effective when given quickly, usually the first hour after trauma. That's why we give it pre-hospital. It doesn't cause clotting. Your body is naturally in a state of clotting and unclotting at all times. What it does is it takes away your ability to break down clots that are already there. So your body will clot up and stop that bleeding by itself, and you won't fight against your own processes. So it doesn't cause strokes, and it doesn't cause PEs, and it doesn't cause DVTs because of that. But if you meet the criteria, please give the TXA early. It'll be a drip, it'll run in. Trauma is going to freak out when they see that running. But I've told them at least 3 times it's going to happen, and they never got back to me. So, send them my way.
Do you want us to put 2 different IVs when you're giving that? From what I gather, you can't do it in the same IV, correct? Like you can't do the antibiotic and then the
TXA?
in
I
the
don't know if
same.
they're compatible. I honestly don't know.
So you,
Ideally, if you had a choice between the two, I'd rather have the TXA because it'll save your life.
okay, so you just wanna do one or the other then?
Well,
Well,
all
the-
your trauma patients should have at least 2 lines anyway.
What, can't get to it.
Then the TXA
Anything possible in
is
biology?
gonna go in super fast. Like,
Okay,
in the hospital, they give it an IV push. The only reason it's in a drip here is because if you put it in too fast, you can cause hypotension.
okay, so,
But TXA is your first line, and then you can do the antibiotic if you have to pick and choose. Hopefully, you're not in that situation. Ideally, too. You know, a trauma patient, you can drill them too.
Fluids and TXA would be my first line. And then antibiotics are nice, but they're not, that's not what's gonna save their life in the first 24 hours. Don't use TXA in isolated head injuries or pediatric populations. It's not gonna help. So if all you have is just the head injury, it's not an indication to use it. Bleeding and extremity trauma, I don't think would change much except for, once again, the antibiotics if you see open bone. Treat their pain. If you put a tourniquet on, don't take it off. If you put a tourniquet on, don't put it on the joint. Put it where it should go. Burns. The only thing that really changed in the burn side of things are some specific ones. So hydrofluoric acid is a common boat cleaner. So it's pretty common out here. It actually, initially it'll get on your skin and you won't see anything. Then 30 minutes later, an hour later, you start to have intense pain because your nerve endings are dying. And you still don't have anything. It looks okay. And then eventually the redness and swelling will happen. The only way to treat that is with calcium. So take your calcium gluconate, mix it with KY jelly, put it in a glove, slap the glove on their hand. And just massage it in there so it coats them. That will actually precipitate out the toxin. That's the only thing that's going to help them. So y'all can do that pre-hospital and transport. But that's still going to be a burn. I mean, that's going to mess up their hand bad, but this is the only thing to stop the actual burning process.
Is there a redosing of that? You put it on, take it off, put it back on, or you just leave it on?
Leave it on. It'll just work in. Clorox, if you get it, you can flush it with milk or Ville. If not, flush it with fluids. White phosphorus is a specific thing I put on here, and not because I'm worried y'all going to get like phosphorus bombed. We're not in Syria. But it is an active ingredient in a lot of the chemical plants around here. Its ignition temperature is like 70 degrees. So
Wow.
the problem is it'll ignite, they'll get burned, and then we get there, and if we don't treat them appropriately, it will reignite. Often it gets in their eyes, and their eyeballs will reignite, which is never good for them. So cover them with soaked in water, rags, and everything. That will prevent reignition. If it's on their eyes, put rags on their eyes and soak them in water and keep them that way. Because the last thing I want to do is someone's eyeballs lighting on fire in the back of the truck on the way to the hospital.
That would be.
I don't want anything on fire in the back of the truck.
As an aside, of course, no like FaceTiming or Snapchatting if that happens.
No.
That's against policy. We already did this once. No matter how cool it is. Electrical and lightning injuries, this is a specific beast because if you think about the actual voltage and amperage from a lightning blast, even though they may look okay, they have multi-system organ damage from that blast. Same thing for high voltage electrical injuries. Try and find your exit and entry wounds, but know that despite the minimal outside damage, they have probably roasted most of their insides. So prepare for the worst. If they are down after a high voltage injury, start CPR and transport them. They will have fixed dilated pupils and no reflexes, but can still have viability. It's just because they have a constant reset from that much electricity in their brain, and they will show no signs of life. So I would rather, in doubt, you don't know downtime, work them to the ER and I can call them there. And then treat the burns if they actually have the burns. Thermal injuries, the only known thing is if you are worried that they have an inhalation injury, take their airway early and do that whole first pass success deal. Because the more you muck with an airway that's burned, the more it's going to swell. But if they have carbonaceous sputum, you look and their nose is all burned inside there and they got it all in their mouth and they talk like this. And you ask them, do you normally sound like that? And they say, no. Then you probably should take their airway. That is gonna be edematous. Now, will it happen in 10 minutes? or what happened in 10 hours, there's no way to tell. But at some point, it'll just go, whoom, and it'll swell up and they'll die. Or get a trach. So I'd rather y'all take it early if you're worried about the airway. Now, if none of that's present and they're talking normal, you just monitor them. But if you're worried about the airway, it's perfectly okay to take the airway early. Crush injuries. We change this around majorly. It comes down to a lot of planning and a lot of bicarbonate fluids. You're going to load them up before they release. You're coordinating with the people there to actually time the release from injury. Note your inclusion criteria for how many hours they have to be crushed for this to be in effect. So I mean, that's an extensive crush time. That's what's going to kill all your muscle cells and make you go hyperkalemic when they release you. Not just I got ran over and now it's better now. So you load them before, just before extrication, and then after. You're assuming as soon as you release the pressure, all the fluid's going to flood into the injured areas and they'll go hypotensive, and all that injured stuff will go out into their circulation and they'll go hyperkalemic and code on you. That's why all the fluids and all the bicarb. And if they have open fractures at the end of the day, that gives them that stuff. Envenomations, please don't bring the snake to the ER. Snakes can bite reflexively after death for up to an hour. So that's why you don't mess with the snake even after it's dead. Any local zoo like Moody Park should have a specific antivenom if they've got black mambas, which we don't have around here. But they should have the antivenom. They're required by law to have it if there is one. So bring that with you, please. If it's a venomous bite, splint it below the level of the heart, there is no role for tourniqueting or trying to cut it open and suck it out. That doesn't work. And then just monitor the patient. Questions?
The only thing really applicable, and I remember it now, with TXA is your factor 4 from your hemophiliacs. And then women taking synthetic estrogen, it increases their risk for a DVT. But other than that, you're safe to give it. And even then, it's risk versus benefit with they're taking the estrogen.
Yeah, I'd still give it if they're a multi-system trauma and they're hypotensive. Need TXA, I can deal with the clot later on.
It is compatible.
So these are relatively aggressive protocols I'm giving y'all. I'm giving y'all a lot of tools to work with. Realize that all these medicines can hurt someone if you don't use them in the right context. I tried to pare down the ketamine as much as possible. 6 or 5 doses, different doses. But if you understand why you're giving it, it makes sense to why you're giving that dose. And that's kind of what I want y'all to understand about reading the protocols. The test is not hard. It's intuitive. If you know why you give a certain medicine, it's relatively easy. That's all I got for you. Thank you.
Everybody takes those things.
Everybody will take this test.